On fetal growth and measurements. I have 15 minutes, and it's a topic that I certainly go on for an hour or two. That would go on for an hour or two about fetal measurements. We could probably put you to sleep, but 15 minutes is going to be a little tight. But let me go over some of the very basic things with respect to fetal measurements and focus on the things we do routinely with respect to fetal measurements in obstetrical ultrasound. So what do we do routinely? Well, first of all, we use obstetrical ultrasound to give us information about gestational age. Now, what kind of information? Well, namely, at the time of the first ultrasound in a pregnancy, ultrasound, the measurements and observations from an obstetrical ultrasound are used to estimate or assign gestational age. Very importantly, you don't do ultrasound to gestational age at anything other than the first ultrasound in one's pregnancy. So, in particular, at the time of any pregnancy after birth, the gestational age, your best estimate of gestational age at the time of that subsequent ultrasound is the age you assigned at the first ultrasound plus the number of intervening weeks. So, for example, if a woman comes in the first trimester of pregnancy and based on your ultrasound measurements, as we'll see in a minute, that really means the crown rump length at 10 weeks of pregnancy in the first trimester. If based on your ultrasound measurements on a first trimester scan, you date the pregnancy at 10 weeks, as being 10 weeks gestational age. If the woman comes back 15 weeks later for a second ultrasound in her pregnancy, for any reason, maybe for bleeding or for size less than dates or size greater than dates, doesn't matter what. Before she gets on the table, you know that your best estimate of her gestational age today is 25 weeks. 15 weeks ago it was 10, your best estimate was 10 weeks. Today your best estimate is 25 weeks. Don't change that based on the second ultrasound. If you do, you'll be making a mistake and potentially getting the pregnancy into trouble. Because ultrasound gets less and less accurate for predicting age or assigning age, and therefore your best estimate is always based on the earliest ultrasound. You certainly, at the time of that second ultrasound where you've dated her already at 25 weeks before you even took a measurement, you want to make sure the baby is appropriate in size for 25 weeks. If it isn't, don't change the age. Get worried about the baby if it's, for example, too small for dates. The second thing to do routinely in obstetrical ultrasound, and this applies specifically to the third trimester, beyond assigning age, is to estimate the fetal weight and to assess the weight in relation to gestational age. So if you're doing a 25 or 30 or 35 week ultrasound, namely any third trimester ultrasound, you want to both estimate the baby's weight and make sure that the baby is appropriate or diagnose that it's too big or too small for its age. So how do we assign the gestational age at the time of the initial ultrasound? Well, that depends on when you're doing it. In the first trimester, early in the first trimester, our approach to dating pregnancies at the Brigham and Women's Hospital is not based on the mean sac diameter, but based on what you see within the gestational sac, what you see on the ultrasound. So that we date early pregnancies or first trimester pregnancies as shown in this table. If we see a gestational sac but no yolk sac, no embryo when we're scanning transvaginally, we'll say that it's a 5-week, our best estimate of gestational age is 5 weeks. Of course, that is with the proviso that since we haven't seen an embryo or a heartbeat, we're not sure there's a living ongoing pregnancy. If there is, our best estimate is based on the visualization of a gestational sac with nothing visible within it, that it's a 5-week pregnancy. If we see a gestational sac and a yolk sac but no embryo, we say it's 5.5 weeks. If we see a gestational sac and an embryo that's 0 to 4 millimeters in its crown rump length, in other words, a teeny embryo, we say it's 6 weeks. And once the crown rump length hits 5 millimeters, through the end of the first trimester, we assign gestational age via the crown rump length. So this is how we assign gestational age at our institution in the first trimester at the time of the initial ultrasound. So if a woman has one scan and we see a gestational sac and a yolk sac and no embryo, we say it's 5.5 weeks, as shown here. If the woman comes back 3 weeks later because she's bleeding, we don't use our ultrasound to date the pregnancy anymore. We know that it's 8.5 weeks because 3 weeks ago it was 5.5 weeks. Come the second trimester, if the initial scan is in the second trimester, then we date pregnancies very differently than in the first trimester. If the biparietal diameter and occipital-frontal diameter, the side-to-side and front-to-back measurements are both measurable, we base the gestational age on what we call the corrected biparietal diameter, which is equivalent to the head circumference. We'll see in a minute what that is. If we can measure the biparietal diameter, but we can't measure the front-to-back occipital-frontal diameter, which sometimes happens when the head is lying low in the pelvis, we base the gestational age on the biparietal diameter itself. If we can't measure the head at all because it's really socked way down in the lower segment, then we'll base the gestational age on the femur length. This is in the second trimester. Again, if the initial ultrasound is in the second trimester. These days, I must say, we see fewer and fewer pregnancies whose initial ultrasound is in the third trimester. Most women these days have ultrasounds earlier in their pregnancy, in which case this won't apply. What I'm going to show you on this slide only applies if the initial ultrasound is in the third trimester. We then, if the gestational age by the last menstrual period falls within 3 weeks of the age based on the measurements, we'll base the gestational age on the LMP as opposed to measurements. Measurements aren't very reliable in the third trimester. So if a woman comes in time of her first ultrasound, her LMP would put her at 30 weeks. We take measurements and we do some calculations. If our age based on the measurements is within 3 weeks of 30 weeks, in other words, anywhere between 27 and 33 weeks, we'll base the age on the LMP and not on our measurements. If the gestational age falls more than 3 weeks from the age by measurement, so that a woman comes in for her first ultrasound, her LMP would put her at 30 weeks, but the measurements put her at 26 weeks, then we have a problem. We have a discrepancy. And then there's no one rule. We have to question the woman carefully about the reliability of her memory of her LMP, find out if she had an ultrasound done somewhere else that might be helpful, and so on there. When a third trimester scan, first scan, and there's more than 3 week discrepancy, we have to really dig into the situation a little more specifically. Just some examples of all of this in terms of pictures instead of tables. Here's a transvaginal scan. There is a little gestational sac in the uterus. You can see it's a gestational sac as opposed to some fluid in the endometrial cavity. First of all, because it is beside the cavity, this line is the potential space of the endometrial cavity. So it's beside it instead of within it. Also because there's an inner ring and then a brighter outer, an outer ring around it. The double decidual sac sign indicates that this is a gestational sac. But we don't see anything within it. We don't see a yolk sac. We don't see an embryo. I don't measure the mean sac diameter here to date the pregnancy. I say, based on the table I showed you before, based on the fact that there's a gestational sac but no yolk sac or embryo, this is a 5-week pregnancy. Here's a little real-time video clip. You can see gestational sac, a yolk sac, but nothing else. No embryo, no heartbeat. Based on the table I showed you before, this is a 5.5-week pregnancy. Again, with the proviso that because I'm not seeing a heartbeat, I can't be sure that there's a living, ongoing pregnancy. But if this is a good pregnancy, my best estimate is that it's 5.5 weeks. Here is a third case. We see a gestational sac, a yolk sac, a little embryo with a heartbeat, too small, barely measurable, 1 millimeter or 2 is the length of the embryo. Because the crown rump length is less than 5 millimeters, when we see an embryo with a crown rump length less than 5 millimeters, we date pregnancy at 5.5 weeks. And finally, once we see an embryo that measures over 5 millimeters, 5 millimeters or greater, base the gestational age on the crib rumpling. In the second and third trimester, our primary measurement for age determination is our measurements of the fetal head, which on the standard plane that you'll read about, you'll see this, the midline echoes, and the midline is symmetric between the two sides, the hypocoecthalami, the cavum, septum, pellucidum seen here in the classic description. And then we measure leading edge to leading edge for biparietal diameter and mid-skull to mid-skull for the occipitofrontal diameter. The same standard view of the head is used if you want to do a head circumference. Here you get a perimeter all the way around the head. Now, I mentioned that the classic view that you'll read about includes the cavum, septum, pellucidum. In real life, we often don't see it and don't even necessarily look for it. As in this case, this is a nice biparietal diameter with a midline symmetric. The midline echoes are nice and symmetric, hypocoecthalami. Even though I don't see the cavum, septum, pellucidum, I'm confident it looks like the right plane. We haven't cut back into the posterior fossa here. You turn to maximize the length, and you get a good BPD and OFD or head circumference. When you're measuring the femur length, make sure to get nice squared off ends and avoid this. You sometimes see this little spur of echogenicity off the end. This is actually off of the epiphysis on the edge of it. Don't include that. Once you've taken your measurements, we use something called the corrected biparietal diameter, but it's equivalent to the head circumference. Notice if you have these two heads schematically, one is somewhat brachycephalic or short front to back, and one is a little more dolichocephalic, longer front to back. If you base the gestational age estimate on the biparietal diameter alone, you would give these fetuses the same age because they have the same BPD. Even though this head is actually bigger than this head, bigger in terms of its circumference or cross-sectional area. So the biparietal diameter ignores the head shape. It just looks at one dimension. The head circumference, we do biparietal diameter. Any measurement that takes into account both the width and the length of the head is more accurate than the BPD alone. The corrected biparietal diameter is a simple calculation based on the BPD and the OFD as shown here. I won't go into it in any great detail, just to mention that if you have a head of average shape, the corrected biparietal diameter is exactly the same as the BPD. If you have a short head, a brachycephalic head, the corrected BPD is less than the BPD, and if you have a long head, it's bigger. Just by example, this is a normocephalic head, an average shaped head, and where we've measured the BPD and the OFD, when we correct the biparietal diameter, it started out at 57.6 millimeters or 5.76 centimeters, and it ends up identical because the head is the same. Whereas with a dolichocephalic head like this one, a long head front to back, the corrected biparietal diameter, the uncorrected one, is 58.8 millimeters, 5.88 centimeters. The corrected one is bigger. It's about 7 centimeters or 71 millimeters. And what we do is we use the corrected biparietal diameter instead of the biparietal diameter. What the corrected BPD is actually is the biparietal diameter of the average shaped head that has the same cross-sectional area as this one. So if you had an average shaped head with this area across it, it would be shorter and wider at a BPD of 70. So if you date pregnancies the way that I showed in the earlier slides at the time of the initial ultrasound in the first, second, or third trimester, your accuracy is going to be highly accurate in the first trimester to about within a half a week, a half to 2/3 of a week when you date based on ultrasound in the first trimester. Only moderately accurate in the second trimester, and not very accurate in the third trimester. And this is why we never redate pregnancies. If we have an early ultrasound and then a later one, we always base our age on the later ultrasound. In the third trimester, in addition to assigning age, we estimate the weight. And here is where the abdominal diameter comes into play. We'd never use abdominal diameter to assign age. It's just not very accurate for age. There are tables you could use, but we don't because it's not accurate. But we do use it to estimate the weight of the baby. And the more body parts, ideally you want to use measurements of the head, abdomen, and femur. It gives you the tightest fit, plus or minus 15%, for estimating fetal weight. And once we have the age and the weight, we determine the weight percentile via a weight table. Very important to measure the abdominal diameter carefully. You want a nice round abdomen. And be very careful not to mistake a fetal rib for where to put your cursor. You want it on the edges. And it looks obvious here. It's a little less obvious here maybe. This case is actually an image that I reproduced from a legal malpractice case that was sent to me from somewhere else in the country where they grossly underestimated the baby's weight, leading to an attempt at vaginal delivery. The baby got stuck, got into problems because they grossly underestimated. Down here they put their cursors on a rib. Over here I have no idea where they put them. You don't get a good baby or a squish. Say often, but you're better off saying I can't measure the abdomen, therefore I can't, than mismeasure it and give an inaccurate weight. Once you have the weight estimate and the age, you can use a weight table like this to determine the weight percentile depending on your estimate of the weight and your estimate of the gestational age, or a weight chart. The final thing to mention very briefly, calculate a weight percentile and determine if the baby is abnormally small or large for its days. Small is ones that are below the 10th percentile for gestational age, which is sometimes termed small SGA, small for gestational age, or intrauterine growth restriction, IUGR. You're really trying to, so you can figure out when you have a small baby, which of these pies it falls into. It can be due to maternal problems such as hypertension, lupus, substance abuse. And these maternal problems cause placental insufficiency and fetal malnutrition to give small size. Or you can have primary placental insufficiency, one due to unexplained causes unrelated to maternal problems. Other causes of fetal small size include fetal abnormalities such as chromosomal abnormalities or infections. And finally, some babies are small just because they're constitutionally small. They may be genetically small. There's nothing pathologically wrong with them. They just happen to be, 10% of us are in the bottom 10 percentile. It doesn't mean that we're pathologically small. Your job on ultrasound, once you've determined that the baby is below the 10th percentile, is to try as best as you can using ultrasound clues to determine whether that small baby that you found to be below the 10th percentile is constitutional. Well, you're not going to see signs of this. What you want to do is find out either directly from the mother, or the obstetrician can find out whether the mother has any of these problems. Our primary job on ultrasound when we see a small fetus is to look for signs of chromosomal abnormality or infections such as calcifications in the baby's head and other intrafetal calcifications that may be signs of infection. So it's been a whirlwind tour of fetal measurements, but again, you want to focus on accurate estimation of gestational age, the key rule there being only assign age at the time of the first ultrasound, estimate fetal weight in the 3rd trimester, and the key thing there is be very careful to get a good measurement of the fetal abdomen, and finally, assign a weight percentile such that if the baby is abnormally small, below the 10th percentile, use your ultrasound to look for clues as to why that might be. So let me switch rapidly to the second talk that I have to give here, which is on the 1st trimester. in the first trimester has become much more productive and also much cooler these days that we have nice three-dimensional pictures. We also have the ability to see things in great detail with transvaginal scanning and with just higher resolution transabdominal probes. So this is a little eye test, and I'm going to come back to this at my very last slide. Here is what looks like a acute 12-week ultrasound. Let's say the woman came in for bleeding. So look at it for a few seconds, and I'm going to tell you that this baby has something very abnormal with it, but I'm not going to tell you what it is until my end slide. Cute little 12-week fetus. There's a nice heartbeat at a normal rate. There's fetal face and body. Just look at it for a second. Okay. So let me move on to the body of the talk, and then I'll come to that at the end. There are all sorts of things we can do today with ultrasound in the first trimester, from assigning gestational age, which you just heard me talk about, and I won't say anything more about, diagnosing some early pregnancy complications, including early pregnancy failure, also sometimes termed spontaneous abortion, diagnosing ectopic pregnancies, diagnosing and characterizing multiple gestations, the Nuchal translucency measurement, and others. Now, obviously, in 30 minutes, I'm not going to have time to go through all of these, but I'll try and touch on some of the highlights. Well, before you can say anything or make any diagnoses in the first trimester, you have to know the normal sonographic findings in early pregnancy. Most of the problems, at least most of the most cases of early pregnancy failure occur very early on, 5, 6, 7 weeks. To be able to diagnose it, you have to know the normal sonographic findings in early pregnancy. And I've shown here on this slide many of the early normal findings that have been published in the literature. These can be considered milestones of early pregnancy. For example, and I'm not going to go through every one of them here, hopefully they're in my handout, based on gestational age, as we saw in the prior talk, by 5 weeks you expect to see a gestational sac with a double ring around it, by 5.5 weeks a yolk sac, by 6 weeks a heartbeat. So what does that mean? If you're looking for problems, if you have a pregnancy that you know is 6 weeks, 6.5 weeks, and there's no heartbeat, you're going to be worried. And we'll get into those in a minute. There are norms based on the mean sac diameter, based on the beta HCG. For example, by the time the beta HCG by the first or third international preparation is 1,000, you expect to see a gestational sac, and you should be worried if the beta HCG is greater than 1,000, you see no sac, and so on. The yolk sac should be less than 6 millimeters. There are heart rate norms and norms for the appearance of the gestational sac. So again, I haven't detailed every one of them verbally up here, but these are, this slide represents most of the published norms for normal sonographic findings in early pregnancy. How do you use it? Well, if you're doing a scan and you see the appropriate things, you're relieved. If you don't see them, you should be worried. But the key point is how worried to be. When do you use problems with these findings to diagnose first trimester pregnancy failure, a term that I think is preferable to spontaneous abortion? Well, any abnormal ultrasound finding in early pregnancy at least raises the concern for pregnancy failure. Any one of those milestones that's missed, for example, a gestational age that's greater than 6 millimeters and you don't see an embryo, you're supposed to by 6. So if you don't, you're going to be worried. A mean sac diameter greater than 8 millimeters and no yolk sac. From the prior table, you're supposed to see a yolk sac at that point. If you don't, you're worried, and so on. Any of these raise worry. However, the key point is that some of these abnormal findings are more definitive for problems than others. They're all at least worrisome. Some are definitive and some are non-definitive. You have to carefully balance when you're considering making the diagnosis of pregnancy failure early on. You have to carefully balance not being too conservative or too radical in making the diagnosis. What do I mean? Well, If you're overconfident, you're too radical in your diagnosis of early pregnancy failure, an example of that would be to diagnose pregnancy failure or spontaneous abortion when there's some chance of a good outcome. For example, if the beta HCG is 1500 and you don't see a gestational sac, you should be worried because you're supposed to by the time it's 1000. If you said this pregnancy is failed, this pregnancy has spontaneously aborted because the gestational sac is not visible even though the beta HCG is 1500, you would be going too far. You certainly want, that's a worrisome finding, but not a definitive finding of early pregnancy failure. You don't want to go too far in the other direction and be overly conservative. In other words, you don't want to fail to diagnose spontaneous abortion when there's an ultrasound finding that indicates there's no chance of a good outcome. For example, if the crown rump length is 6 millimeters on a transvaginal scan and you see no heartbeat, that pregnancy is definitely a failed pregnancy. And you would be doing the patient a disservice if you fail to diagnose a spontaneous abortion with 100% certainty. So how do you make that careful balance? Not to call it when you shouldn't, but failing to call it when you should. Well, get into it in a minute. Basically, when we do an early ultrasound for problems, you want to, the goal is, and this is early on, put the findings into one of 4 categories. Either there's definite pregnancy failure, in which case no ultrasound is needed. If you see a 6 millimeter embryo with no heartbeat transvaginally, you don't need to get a follow-up. You need to break the unfortunate news to the patient, tell the obstetrician, but no, you would be doing a disservice if you left any sliver of a hope in the patient and got another scan. Another category to put it into is possible or probable pregnancy failure, in which case you want to rescan in a few days to a week. Another category is the baby is now alive, but you see a finding that puts the pregnancy at elevated risk of subsequent pregnancy failure, in which case you'll also rescan several days later or recommend it. And final category is normal, in which case, of course, you congratulate the parents on their normal early pregnancy and no follow-up is needed. So how do we put these rules into play? How do we get these categories? There are 2 main situations that I'll diagnose a definite failed pregnancy. One of them is the one I mentioned just a minute ago. If I see a crown rump length 5 millimeters and there's no heartbeat, or if I know the gestational age is 6, or for a margin of safety 6.5 weeks, and there's no heartbeat, I'll say there's a definite failed pregnancy. Now, notice this, not notice, but by this I mean definitely greater than 6.5 weeks. If the woman's LMP puts her at 6.5 weeks and I see no heartbeat, I don't say that's a definite failed pregnancy because the LMP is notoriously unreliable. But if I know it's 6.5 weeks based on an earlier ultrasound or based on an in vitro fertilization, embryo transfer, and there's no heartbeat at 6.5 weeks, then it's a definite failed pregnancy. Basically, any other milestone I consider worrisome, but not definitive. Finally, if there is a heartbeat today, there are certain findings such as a slow heart rate, a large subchorionic hematoma, a large yolk sac, low amniotic fluid volume in the setting of a positive heartbeat. Any of these findings I'm worried about, and I will also get a follow-up scan. So just several examples of these rules. Here is a crown rump length of a little over 5 millimeters, 5.38 millimeters, measured here, and on this clip there's no heartbeat. This is definite pregnancy failure. No need to get a follow-up ultrasound. You need to beat around the bush. It's unfortunate, but it's a definite failed pregnancy. What about this case? It's a case just from a few days ago that I saw actually. Here is the yolk sac. There's the embryo. It's measuring 3.5 millimeters. And on the real-time video clip, there's no heartbeat. Does this pregnancy have a chance of making it? Not much. Almost 0. But the key word there is almost. And the literature has examples. Cases like this aren't often going to turn out to be normal pregnancies, rarely, but not never. It's not 5 millimeters. However, this case had an extra piece of information. So based on the 3.5 millimeters and no heartbeat, I would have said, I'm very, very, very worried that there's almost no chance, but get a follow-up. Actually, there's some new information in this case. Namely, she had a yolk sac a week earlier, which put her 5.5 weeks at this time, 6.5 weeks at this time, and therefore it's a definite pregnancy failure, not based on the measurement with no heartbeat, but based on the age of 6.5 weeks and no heartbeat. Mean sac diameter greater than 16 millimeters and no embryo. Here's a 20 millimeter mean sac diameter. There's a yolk sac but no embryo. You're supposed to see an embryo by 16. So are we worried? Yes. Are we going to write off the pregnancy? No. It's not a definitive finding. It's a very worrisome finding. We've got to follow. The next category is elevated risk of subsequent pregnancy failure. Here's a living embryo. There's a heartbeat. It looks slow. It measures slow, 70 beats per minute. And this pregnancy is almost certain to die within a week or two after this. So we would get a follow-up, but it's alive today. Categories that we use, we consider anything under 90 up to 6.2 weeks as slow, and less than 110 at 6.3 to 7 weeks to be slow. A small subchorionic hematoma is basically irrelevant, but a large one like this embryo was alive at the time of this. There was a heartbeat in real time. Large subchorionic hematoma undermining some of the placenta here and probably over here. This is very worrisome, but it's alive today and it may make it. So this merits close follow-up. Another finding that even though the baby is alive today, the fetus is alive today, there's an elevated risk of subsequent pregnancy failure is a large yolk sac. Yolk sac should measure under 6 millimeters. Here it's actually measuring 9 millimeters if you can read the print. This is at 7 weeks. Normal heart rate at 7 weeks, but a large yolk sac. And on follow-up a month later, it was no longer alive. I don't find the large yolk sac, in that case it was very helpful. It was the only abnormal finding. Usually when I see a large yolk sac, I also see a dead embryo or something that is even more definitive. So I don't very often find the yolk sac size to be helpful, but it can be. Let's move on to a brief discussion of ectopic pregnancy, which are mostly seen in the 95–97% are seen in the ampullary or isthmic portion of the tube, but they can occur in rare locations as well. So about 95% are in the main part of the tube, the extracorneal part of the tube, about 5%, but even more, a higher percent in pregnancies achieved via assisted reproductive technologies such as IVF. Can be in uncommon locations, including heterotopic, one in the uterus and one ectopic, or in the cornu or interstitial portion of the tube, in the cervix, and other unusual locations. The ultrasound diagnosis made in the clinical setting typically of a woman who is what we would term a rule-out ectopic patient, a woman with a positive pregnancy test and symptoms of pain or bleeding. When we're doing an ultrasound in a rule-out ectopic pregnancy, or a rule-out ectopic patient, the key questions are really two. Do we see an intrauterine gestational sac, in which case an ectopic is almost completely excluded? Second key question is, are the adnexa abnormal? And the key point here is the adnexa outside the ovary. Lesions inside the ovary in a woman who's pregnant are basically irrelevant. It represents corpus luteum, which can look like anything. How do we put those two key questions together? Well, this table comes from a paper published several years ago in radiology by Rusty Brown and myself. Rusty used to work in our department. If you have a rule-out ectopic patient, a woman with positive pregnancy test, bleeding and pain, and nothing in uterus, then we can come up with a table that gives a likelihood of ectopic pregnancy based on the exal findings outside the ovary. Basically, if you have a rule-out ectopic patient with nothing in the uterus and the adnexa are normal outside the ovary, the chance is high, generally over 90% and up to 100 if you actually see an embryo or yolk sac in the adnexa. The chances are high of an ectopic pregnancy. If you have a woman, a rule-out ectopic patient with nothing in the uterus, and the adnexa are normal with or without an irrelevant ovarian lesion, the numbers drop to about 5%. So they're low, but far from zero. In other words, a woman who has a positive pregnancy test, pain, bleeding, normal ultrasound, about a 5% chance of an ectopic pregnancy based upon her symptoms and positive pregnancy tests alone. So just a few examples. Here is heartbeat outside the uterus in the left adnexa, nothing in the uterus. This is a definite ectopic pregnancy. Another example here is gestational sac outside the uterus, got a heartbeat in it. That's easy, straightforward, definite ectopic pregnancy. Another case of a definite ectopic here in the adnexa. We can see a heartbeat documented by M mode. There's fluid in the endometrial cavity, sometimes termed a pseudo-gestational sac. It's not a gestational sac, doesn't have any of the characteristics, and moreover, there's a pregnancy in the outside the uterus. Again, nothing in the uterus. In the ovary, there's this hypoechoic mass, but that's irrelevant, that's corpus luteum. But importantly, out here in the adnexa, there is a gestational sac. How do I know it's a gestational sac? It has fairly characteristic bright ring around it, sometimes termed a tubal ring, which would indicate an almost 100% chance of an ectopic, but what makes it 100% is that there's a yolk sac in there. This is a tubal ring with no yolk sac in it. Uterus, ovary, tubal ring, over 90% chance, about a 95% chance of an ectopic. And another, again, in the clinical setting of a woman who comes in as a roulette ectopic patient. Another roulette ectopic patient, nothing in the uterus, and a tremendous amount of blood and clot, both clotted and unclotted blood, filling the pelvis in both sagittal and coronal or transverse views. In this clinical setting, positive pregnancy test and nothing in the uterus, and pain and bleeding, very high likelihood of ectopic pregnancy. So I mentioned that lesions inside the uterus inside the ovary are irrelevant in a roulette ectopic patient, in any patient with a positive pregnancy test. They're just corpus luteum. Ones outside the ovary are very important. They indicate an over 90% chance of ectopic pregnancy. Not always so easy, though, to tell whether something is inside or outside the ovary. I mean, is this thing, if this is the ovary, is this thing on the edge? Is the margin of the ovary here, or is the margin of the ovary here and it's outside? Similarly, is this beside the ovary, or is that the ovary? And is this thing beside or outside? Not always so easy to tell. Based on follow-up, this patient had an intrauterine pregnancy that went on with uncomplicated. Presumably that was hanging off the edge, even though it has a brightish ring around it. These two patients both turned out to have ectopic pregnancies. How do you tell? Well, one way to tell is as shown here. Uterus, ovary, is this the edge of the ovary here, in which case this is an irrelevant corpus luteum, or does the ovary end here? Well, one way to tell is by pushing on it. And when we push here, you can see this thing slides along the ovary as opposed to moves within it. So it's beside the ovary, and therefore a mass of an almost certain ectopic pregnancy. Doppler I don't find to be very helpful. In general, if there's something to Doppler, then you have your answer anyway. Namely, if you see a mass to Doppler, there's a mass. And I just told you before that a mass in a patient outside the ovary, and a patient who has a positive pregnancy test and symptoms indicates an over 90% chance of an ectopic pregnancy. Is your Doppler going to turn it from almost certain to certain? No, so who cares? And this is a typical example. There was the ovary, there's a mass beside the ovary. We can get a great ring of color around it and low impedance flow. But the fact that we already saw a mass before we turned on the Doppler told us we had an almost certain ectopic pregnancy. So the Doppler is a waste of time in many cases. So the overall diagnostic approach to ectopic pregnancy is to scan transvaginally and put the ultrasound into one of four categories. You either see an intrauterine pregnancy, in which case an ectopic is virtually excluded. Certainly you want to look for it, but unless you actually see an embryo out there, you can be confident you see an intrauterine pregnancy that you've excluded an ectopic, especially in naturally conceived pregnancies. If you see no intrauterine pregnancy and no adnexal mass outside the ovary, you can say that ectopic is possible, but unlikely. It's about 5% chance in a roulette ectopic patient. If you see no intrauterine pregnancy and an adnexal mass outside the ovary or a large amount of free fluid, it's a probable ectopic pregnancy over 90%. And if you see an embryo or yolk sac outside the uterus, it's a definite ectopic pregnancy. If the transvaginal scan is inadequate, there may be a fibroid in the lower segment, you can't see through it too well, do a transabdominal scan. And if the transabdominal ultrasound is equivocal for an adnexal mass, which doesn't happen too often, it can be useful then and only then to do Doppler. A couple of unusual type ectopics that's worth knowing how to diagnose, especially these are very unusual in naturally conceived pregnancies. They're quite unusual, but they're less unusual in pregnancies achieved via IVF and other such techniques. Corneal Ectopic is one implanted in the interstitial part of the tube, which goes through the cornua of the uterus. You have to be careful to distinguish that from a gestational sac in one horn of a duplicated uterus. Diagnose corneal ectopic when you see little or no myometrium around the superolateral edge. As described here in these rules, little or no myometrium around that aspect, it's a corneal ectopic. Myometrium around the entire gestational sac is in the uterus. So that a couple of side-by-side examples, little fluid in the endometrial cavity. More importantly, the gestational sac is out here in the right adnexa. In the right cornea. There is bright trophoblastic tissue, but no hypoechoic myometrium around the edge, unlike this eccentric sac that has plenty of myometrium around it. This is an intrauterine pregnancy. It happens to be in a bicornuate uterus. Emergency, no emergency. This pregnancy has a good chance of making it. And another side-by-side pair. This is a corneal ectopic, no myometrium around the lateral aspect. Similarly here, there's a heartbeat, trophoblastic tissue, but no myometrium. And here's an intrauterine pregnancy in a bicornuate uterus again. Fluid in one endometrial cavity, pregnancy in the other. A cervical ectopic is another unusual or uncommon ectopic that we see more and more of these days. The main distinction here is distinguishing a cervical ectopic pregnancy that's implanted, by definition, is one that's implanted in the uterus, in the cervix, from one that's just passing through, spontaneous abortion in progress. If you see a nice, well-formed gestational sac, especially with a heartbeat, you have an almost certainly, as opposed to one passing through. If it's flattened and irregular, and either no embryo or at least no living embryo within it, it's almost certainly a spontaneous abortion in progress. Are those rules perfectly 100% reliable? Not. Well-formed sac, prominent embryo, cervical ectopic, flattened irregular sac in progress. But if you're not sure, the rules aren't perfect, you're at all uncertain, you can wait if it's dealing with a cervical ectopic. If it's changed or more likely gone, it was a spontaneous abortion in progress. Well-formed gestational sac, it had a heartbeat. This is a cervical ectopic, flattened irregular sac, no heartbeat, no embryo seen, spontaneous abortion in progress. Well-formed sac with a heartbeat, this is a cervical ectopic pregnancy. In this case, there's a not terribly well-formed gestational sac. No embryo was seen within it. We were quite sure, almost 100% sure this was a spontaneous abortion in progress. But you might get 100% sure if you're dealing with something as potentially life-threatening as a cervical ectopic pregnancy. Waited a day, and it confirmed our suspicion. It's all gone. Final thing I'll talk about briefly, and this is important, is the Nuchal translucency measurement. There's always between about 9 and weeks a little loosened or hypoechoic area in the space behind the fetal neck. You can almost always see it and measure it. When there's thickening, that's associated with chromosomal abnormalities, with cardiac and other structural anomalies, and an elevated risk of pregnancy loss. Here's a nice normal thin hypoechoic space. We measure just the dark area, not the bright tissues behind the spine or the skin. And here's one that at least looks thicker and measures thicker. Fetuses with thickened translucencies, and we consider anything above 2.2 at 10 weeks, 2.8 at 14 weeks, and linear scale in between to be too thick. have an elevated risk of abnormal chromosomes or aneuploidy, especially if they're septated. Trisomy 21, 18, and syndrome are the ones most closely associated with thickened nuchal translucencies. And even if the chromosomes are normal, if the translucency is thickened, there's an elevated risk of an adverse outcome, such as spontaneous abortion or cardiac or other anomalies. So I think it should be routinely measured. Be careful not to mistake the amnion for the nuchal skin surface, as I'll show you in a minute. It is ideally done in the setting of a comprehensive ultrasound and serum marker program. We have one at the Brigham, and there are others around. If the karyotype proves to be normal in a fetus with a thickened nuchal translucency, the patient should be offered a follow-up scan at about 18 weeks to check for anomalies, because there's an elevated risk of those. Example of a thick nuchal translucency in a baby with a fetus with trisomy 13, another one with trisomy 18, a septated nuchal lucency in one with Turner's syndrome. And again, be careful not to mistake the amnion here for the skin surface, which is here. This is a nice thin nuchal translucency in these cases. So my final slide, this harkens back to my first slide. Two phases looks to be normal, but it's distinctly abnormal. Why is it distinctly abnormal? One of the things you want to do is measure the nuchal translucency. You can't see it. I mean, you don't see a second skin line here. In fact, so that should give you a clue that something's amiss. In fact, when the baby bounces up, you can see it's thick. This baby had trisomy 21. I've come to the end of a whirlwind tour of measurements and the first trimester. I certainly hope it's been useful to you. Thank you for your attention.
Thank you very much. It means that 14 weeks. So as his slides attest, we measure the nuchal translucency between 11 and 14 weeks. So
yeah. I mentioned that you can usually see it, but the time that we measure it is
11 and 14 weeks. Okay, moving right along. We're now going to shift our gear a bit into gynecology. First of two lectures on that will be on the uterus. Mary Frady's another one of my associates at the Brigham Hospital, where she's associate professor of radiology and assistant director of the fellowship program, is going to talk about the uterus. Mary?
Thank you, Faye. Okay, I heard you guys already say that your brains are full, so everybody go like this. Let some stuff come out, and we'll put some more on the other side. So you know, all right, never mind. Let's not go there. When you look at the uterus transabdominally, you can look at it, there are a couple different positions that you can see. Sometimes we see a uterus that's retroverted, and the retroverted uterus, the entire uterus, with the exception of the cervix, is directly posteriorly. In contrast, the retroflexion uterus, most of the uterus is anterior, and then just the fundus bends. And these you see with, these are transabdominal, of course, to a full bladder. Transvaginal study of a normal uterus. We see an anteverted uterus with the fundus over to the left, the cervix is down here, and a nice linear endometrial stripe. Here's the uterus coronally, again, a beautiful linear stripe, and we're up in the region of the fundus there. When you measure the endometrial stripe, and a lot of what we talk about with the uterus has to do with what the stripe measurement is for postmenopausal bleeding patients, for any patients who are bleeding, for IVF patients, infertility patients. The endometrial stripe must be measured transvaginally, and it must be measured on a true sagittal image of the endometrium. It cannot be off-center. The measure reported is the thickest point from the anterior posterior endometrial junction. So there are areas that are thin, areas that are deep. And if there is an equal area, that should be part of your report as well. If there's fluid in the endometrial cavity, that is not included in the measurement. So here is a measurement done in a retroverted uterus. The cervix is here, the fundus points posteriorly, transvaginally, and we see a thin linear stripe with a measurement of about 2 millimeters. This is the menstrual phase of the cycle, where the stripe is thin, linear, and under 4 millimeters. As the menstrual cycle progresses, we get into the proliferative phase, where we see a multi-layered look. Now we have a transvaginal image, again, of an anteverted uterus with the fundus over to the left. And you see the multi-layer stripe, and the endometrial cavity is right here, but is collapsed. And this should measure between 4 and 8 millimeters in the proliferative phase. Following ovulation in the second half of the cycle with progesterone effects, we're into the secretory phase. This is when the lining becomes homogeneously echogenic and typically is thicker than 7 millimeters and up to 14 millimeters prior to the onset of menses. And in this patient, we see about a 10 millimeter thickness. Here's an example of a patient who presented with a little bit of fluid in the endometrial cavity. And frequently when patients present with menses still ongoing, we do see a little bit of fluid in there. And you can see that we've chosen to measure the front stripe and the back stripe, 0.12 millimeters and 0.14. So this endometrium would be linear at 2.6 millimeters. So you add the two measurements together, do not include the fluid. In a postmenopausal uterus, the uterus shrinks down in size, it becomes atrophic, similar in appearance to before the onset of menarche. If you've done any pediatric radiology, you notice that the cervix is bigger in size in relationship to the uterus. The veins around the periphery of the uterus can dilate, and vascular calcification can occur in the arcuate arteries. And this is a postmenopausal uterus where you see that the cervical component of the uterus is just as big as the uterine body and fundus, and you have these speckled calcifications that run all along the surface of the uterus, somewhat linear. And you should not be mistaken for fibroids or for some horrible tuberculosis infection. That's normal postmenopausal calcification. A few minutes now on the thing that I get the most questions on whenever I speak about the uterus is what's a normal endometrial stripe? Well, a normal endometrial stripe in a premenopausal patient very much depends on the stage of the cycle I just heard, but should typically be under 14 millimeters, anywhere from 1 to 14 millimeters. The premenopausal patient doesn't seem to be where the issues arise. It's the postmenopausal patient that everybody needs to know that they're falling into line with standard of care in terms of what's considered normal and what's considered abnormal. So the numbers that we use are that 4 millimeters or less is clearly normal. If the endometrium measures between 4 and 8 millimeters, and this is a patient who has no symptoms and no hormones. So this is a patient who's in for, I don't know, maybe a palpable mass in the adnexa or left lower quadrant pain, not problems. 4 to 8 millimeters, we still would consider that patient normal because she is asymptomatic. Anything over 8 millimeters, we would recommend that that endometrium be evaluated further. Here's a patient who's on hormones and is not having symptoms. Here, again, you need to make sure you know whether the patient is on sequential hormones, therefore bleeding each month, or a patient who is on non-sequential hormones not having withdrawal bleeding. If the endometrium is less than or equal to 4 millimeters, again, that's clearly normal, regardless of whether the patient is on hormones. 4 to 8 millimeters, once again, probably normal. We probably consider that normal. If the patient is on unopposed estrogen with an endometrium of 8 millimeters, that patient requires a workup from an endometrial biopsy or sonohistory. If the patient is in a combined estrogen-progesterone cycle where they're having withdrawal bleeding, then we would recommend that they return in 1 or 2 cycles just at the end of menses to reevaluate the endometrium prior to intervening. What about the patient who presents with abnormal bleeding, either bleeding between normal withdrawals, scheduled withdrawal bleeding, or bleeding in a patient who is not on hormones or a patient who is on hormones and is not supposed to be bleeding? So even because the bleeding is happening when it's not supposed to happen. Again, less than 4 millimeters, the patient does not need to have intervention. It's not normal anymore because now the patient's bleeding, but you don't need to intervene. Typically that is due to superficial ulceration or endometrial atrophy, and the clinician may decide to treat the patient with hormones to sort of toughen up or thicken up the endometrial lining, but doesn't need that patient does not need a biopsy. If the patient comes in with abnormal bleeding at any time during the cycle and the endometrium is over 4 millimeters, now you need to work them up. We would start with sonohistogram. An endometrial biopsy in the office is successful or will have a high incidence of diagnostic answer only if you have a diffuse process. If you do a pipelle or focal biopsy in the office and you have a focal process on the other side of the uterus, you could miss that. So depending on whether the abnormality is focal or diffuse, that should guide how the workup is going to go. So sonohysterography I've mentioned a couple times already. This can be very useful to evaluate an irregular or thickened endometrium. I've also found it useful when there's a patient who has abnormal bleeding and a fibroid uterus where it's very difficult to figure out whether the endometrium is getting displaced or pushed off to one side or involved by a submucosal fibroid. So what we do for sonohysterography is a very small catheter is inserted into the cervix in the ultrasound department, and we typically have a gynecologist come down to the department and do that cannulization for us. And then sterile saline is injected through the catheter, and we image the patient transvaginally. Here's a patient that I was talking about before where you really just can't find the endometrium. We just couldn't tell where it really was in there. Is this a little bit of it here? Not really sure. We think there's a fibroid in there, but is this the endometrium sort of bending over the fibroid maybe? Very hard to see where the endometrium was. But yet when we did a sonohystogram in this patient and distended the cavity with fluid, you can see the catheter coming in through the cervix here, and that once the cavity is distended with fluid, the endometrium is thin and linear, and there are no focal defects whatsoever. And although the patient does have fibroids, there's no submucosal involvement. Very briefly, just a couple of uterine malformations. I'm afraid I'm going to send you back to the books if you really want to go through all of the Mullerian duct developmental malformations. But just to talk about a few, if both sides of the Mullerian ducts don't develop, then you'll have uterine aplasia. If there's unilateral lack of development, you get a unicornuate uterus. Here's a patient who did have that anomaly. Here's her endometrium over on the left side. Her uterus was displaced to the left, but it looks like a reasonably normal uterus over to the left with the linear endometrium. But over to the right, sitting far lateral, here's the iliac vessel here. Way over to the right, we found this soft tissue mass separate from the ovary with a thick endometrial area in the center, and this was confirmed with MRI that there was a sort of a right-sided uterine remnant with a unicornuate left uterus. And the reason that you need to be concerned about these or be aware of these is in patients who have duplication anomalies of the uterus, it's very common that there are renal anomalies as well. And in this patient, here in the right upper quadrant, we see where there should be a kidney and there indeed is not a kidney. So if you're looking at GYN anomalies and this is a patient who may have surgery for infertility or surgery for a cyst, you do want to make sure that the referring clinician knows that there's only one kidney in that patient. Another uterine malformation, failure of fusion of the two ducts. If this happens, if it's a complete failure of fusion, we see a uterus didelphys. If there's fusion inferiorly but no fusion at the top, that's your well-known bicornuate uterus. Here's a clip of a patient where you notice that we start at the cervix and you can follow up two separate endometrial echoes, one that sort of stays straight and the other that bends off to the right, and this is a bicornuate uterus when these endometria move separately as they get up to the top. And 3D imaging has shown itself to be somewhat, some would say very useful in looking at uterine anomalies. In another patient, a transabdominal view, we see the two cervical areas down inferiorly, and as we scan higher, we identify two separate uteri, and the hysterosalpingogram confirms what we could see on the ultrasound as each cervix is cannulated, and you can see individual uterine horns, basically, with tubes and free spill in a didelphys uterus. A few words on IUDs. These are, in the past anyway, have been very, very densely shadowing structures which we see in the endometrial canal. Some of the risks that patients get into when they have IUDs placed is the risk of perforation. The IUD can work its way or embed itself into the myometrium. Patients with IUDs are at increased risk for infection, particularly the infection that occurs with foreign bodies, so actinomycosis. And also, if the pregnancy does occur in the uterus with an IUD in place, that pregnancy is at increased risk for miscarriage. So here's our standard traditional copper T IUD, where you see in this anteverted uterus the long, straight, densely shadowing structure of the lower part of the T, and you can follow the top of the T beautifully. But here's the new IUD on the horizon that we're starting to see more and more. This is called the Mirena Iud, and this is an IUD that contains hormones that are released from the IUD. And we have found that this is not as easy to see on ultrasound as the old copper Ts or Lippy's loops. And what you see with the Mirena Iud is the lower portion is clearly has a dense echo shadow. You don't see the deep shadow from it, but you see this reverberation from the lower portion of it. And that clearly is, did not come with that patient. There's clearly a foreign body in that patient. As I was taught when I was a resident, there are man-made things and God-made things. And this is clearly a man-made thing in this lady's uterus. God did not make that. But when you turn transversely on it, or coronal, to see up at the top, you see there's some shadowing here, but it's extremely subtle to look for the little shadowing part off here from one end of the T, and maybe a little shadowing from the other end of the T. So it can be extremely difficult to see Mirena IUDs. The other thing that was brought out to me by one of the gynecologists who came down to see IUD placement in one of her patients is that IUDs, particularly this style IUD, are being offered as form of contraception more and more often now to patients who are recent postpartum. So they come back to see the doctor at the 6-week postpartum visit, and that's when they're sliding in these IUDs. And her comment was that, the uterus at 6 weeks, many patients are still having abnormal bleeding, they're still having some cramping following labor with contractions when they nurse, and that the uterus after a delivery is, as she put it, soft as butter. And so it's her sense that when you slide these really soft Mirena IUDs into a recent postpartum uterus, that it's very easy to perforate the uterus or misplace the IUD, and the patient isn't really aware because she's still maybe having abnormal bleeding and abnormal and uterine contractions, which are of course not abnormal at 6 weeks postpartum. So a couple things that can go wrong with IUDs. Here's an IUD that sits too far down in the uterus. Part of it is in the cervix, part is in the lower uterine segment, but there's a big piece of uterus up here that is unprotected from pregnancy implantation. Here's another one. This is a transverse or coronal image of the lower uterine segment, and we can see the IUD, which is actually nowhere in the uterus. And here it is on the sagittal image. We can see the different pieces of the IUD behind. Here's the cervical canal, and here's the back edge of the uterus. Here's a patient who came in status post Mirena IUD placement, and honestly, I know that Mirena IUDs are hard to find, and I hadn't seen very many of them yet, and I'm scanning and scanning and scanning and scanning and looking back and forth and thinking to myself, I know they're hard to find, but I don't think it's in there. And everyone's like, no, they're really hard to find. It's probably there. It's like, I don't think it's in there. I can't find it. And indeed, when we sent her off for a plain film, here it is up here. Yeah, few. That's what I was thinking, few. Because then, literally less than a week later, in comes another patient, and I can't find it again. Now I'm starting to think it's me, because I didn't have this report yet on the first lady. I'm starting to think that, I can't find IUDs anymore, and then here it is down here. So they call me up and say, are you sure it's not in the uterus? Because that's kind of where a uterus could be. And I'm like, it's not, I don't think it's in the uterus. And indeed, they took her to the OR, and it was in the left pelvic side wall. It was not in the uterus. So I agree that Mirena IUDs are hard to see, but you can see them, and you can tell when there's one in or one out. Now, another thing that I want to bring up on here is that, on that last image, the gynecologist who ordered the plain film up in the clinic ordered an AP pelvis. And the radiologists here know that the IUD is never going to be below the pubic symphysis, right? So all this stuff we don't really need. But you know what? We're lucky we caught that one. That easily could have been ripped off the top of that AP pelvis and we wouldn't have seen it at all. So this is that image to get. And if it wasn't here, we'd almost need to go higher because you need the diaphragm to the pubic symphysis if you're looking for a lost IUD. Moving to fibroids, it's hard to find something interesting to say about them these days. These are hypoechoic masses in the uterus, unless I'm doing fibroid, what's that called, that laser and ultrasound sonar, yeah, where they use sound waves to zap. That might be interesting. Fibroids are hypoechoic, they cause shadowing. One thing that's useful if you're trying to decide if there's a fibroid there is whether it deforms the contour of the uterus. Up to 25% of fibroids can have calcification, and probably the best thing that lets you say, yeah, it's probably a fibroid is if there are a bunch of fibroids, then probably they're all fibroids. Here's that case that I showed you before, the lady who has an intramural fibroid, very hard to see the edges of. As opposed to this, when this fibroid is submucosal in location, you can see that the endometrial stripe is split here and here with a little trickle of fluid here outlining the endometrial cavity for us. Now, these are the ones that cause the most symptoms. These are the ones that patients present with very heavy bleeding. And the good news is that if at least 50% is within the lumen, these can be taken out with a hysteroscope. Apparently they can just dig out the fibroid and then the endometrium will regrow right over the top of where the hole is, over the top of the fibroid, and very quickly. Another location for a fibroid are these subserosal fibroids, which hang off the serosal surface and are typically asymptomatic unless they're big enough to push on bowel or bladder and cause symptoms from mass. Here's a patient with a big fibroid uterus, and the sonographer came out and said, here's the uterus measurements, but I can't really tell where the fibroids are, but you need to be aware that there was something else down here. This is a transabdominal image. And see that here's the bladder, here's what that stuff that was down in the back, this is the uterus down here, and the whole thing that was measured was a very, very big subserosal fibroid. And when you get to fibroids of this size, a transvaginal exam obviously isn't going to help, because the vaginal probe, which only penetrates 5 or 6 centimeters, is never ever going to find this fibroid. So you always need to start imaging of the uterus with a look from on top to see if you've got one of these big, big fibroid uteri. Sometimes the fibroids can be located in unusual locations. Here is a fibroid that is growing right in the middle of the cervical canal. You can see it coronally here. Now, of course, the differential for something like this would be cervical cancer in the canal. But the office called down and they could see this fibroid prolapsing through the cervix. So we were comfortable that this was a fibroid in this instance. Sometimes fibroids have atypical sonographic characteristics. In this instance, the fibroid is extremely echogenic, and this is a lipoleiomyoma, where there's a fatty composition to the fibroid as well. Particularly during pregnancy, fibroids can undergo degeneration. Fibroids, we know about a third of them grow during pregnancy, a third stay the same, and about a third shrink. So this one grew rapidly, outgrew its blood supply. Here you can see some fetal parts, amniotic fluid, the edge of the uterus, and this big fibroid hanging off the side, which is necrosed and is filled with complex fluid and debris. And those can be quite painful. The other thing that they can cause, of course, particularly the submucosal ones, is acute bleeding. And this is a patient who came into the emergency room with an acute vaginal hemorrhage, and transvaginal imaging coronally show us the fibroid here with its typical shadowing characteristics, and it is projecting into the endometrial cavity, which is filled with complex fluid. And out in the adnexa, we saw basically a hemoperitoneum, because when this fibroid started bleeding, it not only distended the cavity, caused copious vaginal bleeding, but also bled out the ends of the fallopian tubes and filled her pelvis with blood. It is important to remember that fibroids can be mimickers of uterine sarcomas. You need to think of a sarcoma in the instance where there's a uterine mass that grows rapidly over time, or if there's something funny about the circumstances, so that we saw one very young patient, 20 years old, who had growth of a single fibroid, and that's got to strike you, you know. Fibroids occur in 30% of women, maybe higher in African American population, but usually not in patients in their 20s. When you have a 20-year-old who comes in and the mass is growing rapidly, you need to start thinking about other things. The other thing that I want everybody to be aware of is that there is now a label on a tamoxifen insert that says, from the FDA, that says there is an increased risk of sarcoma in patients who are on tamoxifen. And this is a patient who was taking tamoxifen for breast cancer, and she presented with this midline solid mass in the region of her uterus. Kind of looks like that one patient who had the big mass in the uterus and the big fibroid in the uterus was underneath. But I couldn't find any recognizable uterus in this neighborhood. And then looking out in the adnexa, this is again full bladder, here's bladder here. You can see these solid masses as well as free fluid. And then on the other side, again, or this is a little bit higher, here's an ovary here, but a solid mass, and this is that big solid mass and lots of free fluid. And she went to the OR and was found to have a sarcoma, uterine sarcoma. Quick couple words on adenomyosis. We are identifying adenomyosis with more and more frequency now. The incidence hasn't increased. We're just figuring it out now that we're paying attention and looking for it. This is when the endometrial glands burrow into the myometrium. Patients can be asymptomatic or present with pain, bleeding, or an enlarged uterus, all of which are the presenting symptoms for fibroids as well. On ultrasound, what we see is a thickened myometrium, particularly asymmetrically thickened. You see the endometrium here, and that the posterior myometrium and the anterior myometrium are asymmetrically thickened. You do see those linear shadows, just like you saw off the fibroid, but there are no edges. There's nowhere to measure a fibroid. It's just all of the myometrium that's shadowing in that funny way and looking very heterogeneous. Also, when we look up a little closely, we can see tiny, tiny cysts in the myometrium. and this is characteristic for adenomyosis. And this corresponding hysterosalpingogram tells you why you might see those little cysts, because you can see that the contrast material fills these glands that are dilated within the myometrium, and the uterine wall is presumably out here, and this is the area that we're seeing on the ultrasound. Endometrial fluid should be an indicator to you that for some reason this fluid is not the secretion. It may be because of cancer, it could be because of cervical radiation, or it could be because of an injury during a delivery or during. There's an example of a little tiny bit of endometrial fluid. In this patient, there's quite a bit of endometrial fluid. Infections of the uterus can extend from endometritis, which is a postpartum infection where there are no sonographic findings, except for possibly some tenderness on ultrasound exam, and pyometria, which is pus within the uterus. In pyometria, you see an innocuous uterus with complex fluid in the canal. And again, the same reasons. You have to think the uterus is constantly making secretions and shedding the lining. Things come out of the uterus all the time. There should never be fluid built up inside the uterus. If anything's built up in there, then something's wrong. There's some sort of outflow obstruction. And here's an elderly patient who presented with pain, no discharge, no bleeding, because of course the problem is that her cervix is stenosed, and she had this complex fluid in the endometria that represented pyometra when when they put a catheter in. So I see that brings me to the end of my time. I'm going to stop here, and I thank you all for your attention.